Welcome to the first lecture of the cardiovascular section of the Integrative Systems Physiology course. Our focus today is going to be on cardiac anatomy and the structures within the thorax predominantly. So most often when we're evaluating general cardiac anatomy and blood flow patterns, it's very common to display them in an illustrated fashion and a very simplistic fashion, which is done here. As you can see, there are four chambers in the heart. So the four chambers are the right atrium, right ventricle, the left atrium, and left ventricle. And of course here, there's also color depictions associated with these. So generally, of course, the right side of the heart would be deoxygenated blood that is returning to the heart from the vena cava, right? So we've got the superior vena cava, which returns blood from the upper portions of the body, the inferior vena cava, which returns blood from the lower portions of the body or anything below the heart, and those empty into the right atrium. The anterograde blood into the flow into the right atrium is facilitated by the tricuspid valve. So when the right ventricle is filled and starts to eject, the tricuspid valve closes, promotes anterograde blood through the pulmonary valve. That subsequently goes into the pulmonary circulation through the pulmonary artery. And after it is oxygenated, then you can see that it returns to the heart from the lungs through the pulmonary veins, which are now depicted as red, and it enters the left atrium, subsequently is ejected into the left ventricle through the mitral valve, and then anterograde blood flow is promoted out of the aortic valve through the closing of the mitral valve and the opening of the aortic valve. That goes out to the aorta and is subsequently distributed throughout the body. And so, of course, this is a very simplistic approach to viewing this, and of course we can show a little bit broader perspective of this. Of course, seeing blood, deoxygenated blood coming in from the systemic circulation going through the pulmonary circuit, becoming oxygenated, coming back, and then going out to the body again. Now, the reality is it is somewhat more complicated than that and much more detailed than that. You can see that with more detailed illustrations of the heart within the left ventricle. You can see these trabeculae within the ventricular wall. I think what's important to note is when you're starting to evaluate the heart in these various depictions of it, in most normal physiological situations, it is quite easy to tell the left ventricle from the right ventricle, because what you will be seeing is the left ventricle is far thicker than the right ventricle. And that is because, as we look at this previous slide, the left ventricle has to pump blood out into a relatively high pressure circulatory system, which is a systemic circuit. And of course, that requires significant amounts of perfusion to meet oxygen delivery and nutrient demand throughout the systemic circulation. However, when we look at the right ventricle is, generally speaking, of course, much thinner, right? And that is because it pumps blood into a relatively low pressure circuit, which would be the pulmonary circuit. And so there, what we're looking at is having very small diffusion distances, very delicate walls of the vessels and capillaries to maximize perfusion and maximize diffusion from the alveoli to the pulmonary circulation, and maximize oxygenation and elimination of carbon dioxide in the pulmonary circulation. Okay, so of course, right ventricle being thinner, left ventricle being thicker. Now, when we're looking at what you need to know in these things, of course, in these more detailed figures, I don't expect you to have comprehension and mastery over everything within any given diagram, but we do think that it is important for you to have some degree of detailed knowledge of the anatomy of the system. And this is not an unreasonable sort of list of things for you to understand, which would be the various cusps of the tricuspid valve, as well as the mitral valve. So tricuspid valve, of course, having 3 leaflets, the mitral valve having 2, both the aortic and pulmonary valve having 3 cusps. Being able to identify the left ventricular wall, certainly the ventricular septum, the right ventricular wall on both sides, and then key structures, including the atrial structures and ventricular cavities, as well as the aorta and the pulmonary veins. And I think, when you're looking at these things in pulmonary artery, and of course, one easy way to discern between what is what on a lot of these diagrams is if you can identify various comparative structures. Generally speaking, the thicker the structure, if it's a relatively thicker structure, that structure will belong on the left side of the circulation or the systemic side of the circulation, and the thinner structures, of course, belong to the lower pressure venous sides of the circulation. So again, I think when we look at cardiac anatomy in reality, again, there's far more detail and far more minutia sort of within these realistic depictions and photographs of the ventricles. And what we will work towards in the course is having opportunity for all of the students to do a ventricular and cardiac dissection, where you can really firsthand appreciate a lot of the relative differences and relative thicknesses of the structures within the heart, as well as how detailed a lot of these trabeculae and various microstructures and macrostructures are within the heart. Now, when we look at how some of the structures are named within the heart, there is a very logical naming strategy certainly for the cardiac structures within the heart and the valvular structures in particular. So when we look at the tricuspid valve, for example, of course, it's sensibly named. There are three cusps or three leaflets. So the tricuspid valve separates the right atrium from the right ventricle. And if you look at things from an anatomical perspective, sort of from the top down, so looking in largely through the neck into the thorax, and a person laying supine, what you can see is that these are actually very sensibly named for all three of these. There's the anterior cusp, which would be closest to the sternum, the posterior cusp, which would be closest to the spine, and the medial cusp, which would, of course, be medial to the entire body and relative to the anatomical positioning. Similarly, when we evaluate the mitral valve, you can see that there's an anterior cusp, which, again, facing forward, closest to the sternum. The posterior cusp would be facing or closest to the spine. And again, mitral valve being a bileaflet valve. Really, the predominant difference between a valve cusp and a valve leaflet, the atrioventricular valves are actually leaflets, and the two tricuspid valves, which regulates circulation and flow out of the heart, are cusps. So a cusp would have something that forms almost like a cup, whereas these are simply leaflets that don't really form a cup when closed. Now, the aortic valve, again, very sensible naming system here. You've got the posterior cusp, the right cusp, and the left cusp. And the pulmonic valve, again, very simply named the anterior cusp, the right cusp, and the left cusp. So if you can just think of where these things are, orient yourself with regards to where you are viewing things from anatomically. These are the depictions that you would be evaluated on. And so there, as long as you know what's anterior, what's posterior, and what's medial, you should be able to name all of the valve cusps effectively. Now, what's interesting is that when you actually start to view a heart in vivo or in a dissection, it can often be very difficult to tell the difference between the pulmonic valve and the aortic valve. And largely that's because both valves are very thin structures, and oftentimes when the hearts are removed, the aorta can be damaged, or the pulmonary valve the pulmonary artery can be damaged. And so it can get very difficult to identify structures that would help you identify which is which. Now, the two ways in which you can do that, one is you can take your finger and you can insert it in through the valves and feel the thickness of the ventricle to which that valve is regulating outflow from. That is one way to do it, which works when you are there and have a have the opportunity to actually have tactile evaluation of the tissues when you're not there, or when you're simply just really wanting to know off the cuff without a substantial amount of evaluation, physical tactile evaluation. The easiest way to tell the difference between the pulmonic valve and the aortic valve is going to be to identify the coronary ostia, or the entrances to the coronary circulation. And so, of course, those are only evident near the aortic valve, since the coronary circulation would, of course, want to be perfused by highly oxygenated blood, and so the ostia, or the entry to the coronary circulation, is immediately distal to the aortic valve. Now, again, when we look at these things, with an in vivo picture or a pathological picture, here, you can see that it's actually very difficult to evaluate sort of what is what. And you can see that the mitral valve, tricuspid valve, in the absence of pressure and distension, they tend to retract backwards and require stretching and being held in place by the chordae tendineae, which connect the valve leaflets to the ventricles. So again, much more difficult to identify structures when you're doing a gross dissection. So again, when we look at these things in a little bit more detail, and we look at valve cusp anatomy, when we're looking at the aortic valve, you can see here, again, we've got the right cusp, we've got the left cusp. The anterior cusp is often referred to as the non-coronary cusp. But again, you can see here that it's very clear when we're evaluating the anatomy of this overall structure that the coronary ostia are actually very easy to identify, both in the picture as well as in the dissected aortic root. So, and here's a depiction of everything during ventricular diastole. Now, similarly, when we take a look at the pulmonic valve, what you can see is that the normal pulmonic valve, of course, is histopathologically very similar in structure to what you would see in the aortic valve. And again, there's no intentional size difference here being depicted, although this is a bit more zoomed in. But what you can see is that there's no evidence of coronary ostia on the pulmonic side, and so that will be very evident when you do a gross dissection of the heart. So again, as we touched on, why is it important to have the coronary ostia outside of the valve cusp or the ventricle? Of course, the oxygenation of blood is one. The other is that the heart is actually perfused during diastole. And so what you can think of here is that when you think of muscular contraction, the amount of tension that can be generated during muscular contraction, that's not optimal for perfusion of a tissue. And again, you can think of this just even from the fact of physical contraction. You can generate quite a bit of tension within the muscle itself. And again, the coronary circulation must have a high degree of perfusion, because it's the only muscle that continues, along with the diaphragm, that continues to contract rhythmically for your entire life. And so, from an optimization perspective, you have negligible perfusion of the heart during systole due to this high myocardial tension. And so then when the heart relaxes, the systemic diastolic pressure is actually the driving force for coronary perfusion. And so it makes a lot of sense to have the coronary ostia being distal to the aortic valve. And so when we start to look at the structure of the coronary tree in a bit more detail, what you can see here is we've got the aortic valve, we've got, of course, non-coronary cusp, the right cusp, left cusp. You can see with the right cusp, you have the right coronary artery coming off of that. With the left cusp, you've got the left main coming off of that. And then the left circumflex branching off from the left main, and the left anterior descending being the other branch off of the left main coronary artery. So when we take these structures and we start to place them onto the ventricular anatomy itself, what you can see here, again, we've got the aorta with the valves being embedded deeper within there. And you can see that we've got the right coronary artery coming off of the right side, left main, branching off to the left circumflex, which of course is somewhat circling portions of the ventricle here, and then the left anterior descending, being quite cleverly named for being descending down the anterior portion of the left ventricle. And I think importantly, in most individuals, what you have is the left anterior descending, and it actually starts to dive underneath the ventricular muscle at certain points throughout the coronary circulation and the left ventricular anatomy. So it is important to make sure that there is perfusion during the diastolic portion of the cardiac cycle. So when we start to look at this in a lot more detail, this is the unfortunate part here. This is very difficult to find coronary depictions that are of appropriate detail. And so what you can see here is that there's a lot of detail with regards to the coronary circulation and where we can go into tremendous amounts of granularity. I think the important parts that I would like you to be able to name and be familiar with because of the clinical relevance would be the left main coronary artery and the left circumflex artery, the left anterior descending coronary artery, the right coronary artery, and then the left circumflex artery. And those are the primary arteries that we know are going to be just the suppliers of major portions of the ventricular tissue. Now, when we look at this in a bit more detail, hopefully this depiction is helpful. We've got the regions supplied by coronary arteries here. And so what you can see is if you break out your Mickey Mouse Dakota ring, you've got the left anterior descending, which is going to be in blue, the right coronary artery in white, and the left circumflex artery in this hatched color. And you can see that the left anterior descending artery supplies blood flow to, of course, the anterior portion of the ventricle, quite sizable amount of the anterior portion, a little bit of the right ventricle, but then, as you can see, as you get distally, so further down into the ventricle, or more apical, as the top is the base, the bottom is the apex, you can see that there is a very sizable portion of the ventricular muscle that is in the septum that is supplied by the left anterior descending coronary artery. And similarly, you can see at the apical portions, the predominant amount of the ventricular muscle is actually supported by the left anterior descending. So should you have a blockage in your left anterior descending coronary artery, that is a significant physiological challenge that needs to be intervened upon. Now, when we look at the right coronary artery, as you might expect, it supplies quite a substantial amount of the right ventricle. But interestingly, when we look at the most basal portions of the ventricular structure, you can see that there's the right ventricle, the right circumflex artery and right coronary artery supplying a substantial amount of the right artery, as well as a substantial amount of the septum, as well as a portion of the left ventricle. So as you go more distally, you can see that there becomes a greater amount of exclusivity with regards to how much of the right ventricle versus left ventricle is supported by the right coronary artery. Now, finally, when we look at the left circumflex, you can see here, left circumflex artery is really supplying predominantly the left ventricular muscle here. You can see that becomes progressively smaller as we go more distally. But again, there's a substantial amount of the left ventricle and left ventricular free wall that is supplied by the left circumflex, and that is the only circulation in which there is really exclusivity with regards to the left branching supporting only the left side. Otherwise, there is some blending of the two between the two sides. And again, when we look at this from a sort of long axis view, you can see that there's some significant overlap with regards to left and right of the supply from both the left anterior descending as well as the right coronary artery. So here, we'll pause for a second with regards to just information delivery and say, well, what would happen with a blockage in the left circumflex artery? Now, you would think if we walk through this, we'd say, okay, so we take the left circumflex and then we essentially go find all the portions of this that are aligning with the hatched portion. And you can say, well, what we would have would be, if it's a very proximal lesion, a very substantial amount of ischemia within the left ventricular free wall. And that would be a relatively exclusive perturbation to the circulation to the left ventricular free wall. But I think importantly, what I want you to start thinking about as well is, what are the secondary effects of some of these insults? And because I think it's very easy for you to memorize, this sort of initial insult portion, and you say, well, I've got this depiction of everything that's going on here, but what are some of the secondary complications that might occur? And I think there is a reality here to say, well, there's a potential for mitral valve prolapse if there's a substantial infarction within the anterior leaflet of the papillary muscle. And so, again, here's a case report from the literature that just shows that this, in fact, does happen, and it can be a very sizable insult. So there we've got acute mitral valve regurgitation because of the complete rupture of the anterior papillary muscle, which holds the mitral valve in place during that diastolic portion, so the valve goes to close. And of course, the papillary muscles are what prevents it from prolapsing backwards. So when that ruptures, then your mitral valve just flaps back and forth in the circulation. You have severe regurgitation. And so this individual is a 77-year-old male, complete blockage of the left circumflex artery, subsequent rupture of the papillary muscle, and was treated with open heart surgery and valve replacement. So sort of a doubly bad day for that individual. And so I think what I'd really like to start thinking about is that one event can elicit a cascade of other events. And so really viewing this more as a integrative cardiac physiology approach to understanding not only the primary insult, but also the secondary insults that might manifest both acutely as well as chronically. So we're at this point where we say, well, that's nice, but who really cares? Because I'm not a physiologist, I'm an engineer, right? And I would argue that the understanding of physiological problems is actually very important to help you address significant medical and surgical problems. And so what I'll show you here is just a depiction of a technology that was actually developed here at Mayo Clinic for the treatment of mitral valve prolapse. And what you can see is that this is for a device called NeoCord, so for mitral valve repair. And so when you have mitral valve prolapse, so rupture of the chordae tendineae, you can see here that there's no chordae tendineae holding this mitral valve back, and you have leakage of blood back into the left atrium. And so this device essentially is inserted in through the apex and can be used to grab that free leaflet. And then you can use a lighting system to actually confirm that you have capture of the leaflets. And again, it's incredibly important because if you just put it in there and you say, well, we'll just hope that we grab something, you need to be able to confirm that you actually are inserting a suture through a substantial portion of the leaflet. Otherwise, that'll just rip through and you'll have more problems later. Now, when we look at, again, the technology that's used to reach through, grab the suture, and then subsequently pull that back through and allow the cardiac surgeon to then release the valve, pull this entire device back out of the ventricular apex, and then what you can see, it's a little bit slow here. Of course, there's a very fancy way to end up securing that suture to the leaflet. But the critical portion of this then is that now you have a leaflet, a chordae or a virtual chordae that you can use to adjust the leaflet in real time, so you can actually confirm that the leaflet is functioning in the manner that you would like it to. And confirm that there is no mitral valve regurgitation present within the ventricle. Okay, so you can see here total absence of regurgitation and a successful procedure. Okay, so at that point, you'd say, well, that's an interesting technology. Again, I think it's a perfect example of this intersection between engineering and physiology, and how you can devise a device that you can say, well, this will enable you to adjust the leaflet cusps in real time, the leaflets in real time, so that way you can ensure that there's no mitral regurgitation. But you can still say, well, who cares? I'm an imaging person, and that's what I care about the most. And so again, I would come back to say, well, by knowing what needs to be imaged, both physiologically and clinically, you can also know how to best leverage appropriate technologies. And so here, again, we've got an example, hopefully, of using 3D imaging to actually have a much more granular and detailed understanding of the structure and anatomy of the heart with various permutations here. And so instead of just having a two-dimensional view of the ventricle, you can now have a three-dimensional view of the ventricle and really understand where some of the derangements in valvular function or cardiac function actually reside, which with much more accuracy than you would have in 2 dimensions alone, which also has profound implications for enabling the accelerated execution of procedures and confirmation of lack of dysfunction following cardiac surgeries. So finally, I think you still might think, well, I don't really care, right? And I would say, well, I'll still try to convince you that that physiology is important intersector between biomedical engineering, imaging, and other disciplines. And so I think again, coming back here to say, well, let's focus on the engineering problems and maybe not your lack of general knowledge. And so, by having this general knowledge, it allows you to say, well, how do we devise things that are really unique? So when we look at disruptive innovations that have occurred within, let's say, the last 10 years, transcatheter aortic valve replacement is one that's actually very fascinating. So you can see here in the normal aortic valve, the aortic valve opens up nice and widely, and blood is pumped out through a low resistance system into the circulation. You can see with aortic valve stenosis, the valve thickens, and it becomes much more difficult to pump blood out to the circulation. Now, instead of having a surgical valve replacement, which requires open heart surgery, with transcatheter valve replacements, what they're able to do is take and put a guide wire in through the valve, and then ultimately place a catheter in through that guide wire through a relatively non-invasive procedure, advance that catheter through the valve, and then end up placing a replacement valve within the root, and really using the pressure of the balloon to open up that aortic valve, and then deploying a stented valve structure inside there, right? Instead of going in surgically, opening up the aorta, thorax aorta, and then cutting out the old valve and then suturing in a new valve. So this transcatheter valve approach has been absolutely transformative in terms of the ability to treat aortic valve dysfunction in a relatively non-invasive way. But, and there's a big but here, the availability of this technology has, of course, been limited, and it's very challenging to do this in relatively low-income or low-resource countries where aortic valve disease is still a major problem. And so here, when we look at very disruptive innovations, this one was actually developed by a cardiac surgeon. His name's Peter Zilla. You can view it as being somewhat of a blind TAVR. So this is called straight access technology. And so, of course, the challenge is when you deploy a balloon inside the aortic root, most often, of course, you have a very small amount of time to do that because when that balloon is totally inflated, then you're getting no coronary perfusion, no systemic perfusion. And so it's a tremendous challenge. It requires a lot of imaging to be able to deploy that appropriately in a very timely manner. And so if those imaging resources are not available, how do you do that? And this technology allows you to basically blindly place a transcatheter technology, which is loaded onto this balloon here, into the aortic root. And you can see, of course, it's loaded here. And the interesting thing is that these hooks, once this is inserted into through the aorta into the aortic root, these hooks can be deployed and they can be pulled back then to confirm seating of the valve deployment structure in the appropriate position, and then subsequently you can have deployment of the valve structure with the inflation of these balloons. But you can see here what's very interesting is that they've done this in a way that now there's a hole in the middle here, or a hollow center of this balloon structure. So actually, in terms of coronary perfusion, systemic perfusion, it becomes a relative non-issue, because here blood flow can still flow out through the center of this catheter structure. Right? So even as it's deployed, you can still have coronary and systemic perfusion, which eliminates a lot of the time requirements with the normal TAVR procedures, as well as imaging for that. And so, again, really focusing on the understanding of the limitations of the current technologies and physiological stressors that can be experienced by patients in a variety of conditions, and then ultimately developing new technologies that address some of those significant limitations. So we're going to change gears a bit here. So we're going to go from sort of these pure visible anatomical structures to an invisible structure that enables conduction, which would be sort of the closing portion of this lecture. And so when we're looking at the anatomy of cardiac conduction, what we have is a sinus node, which is really the pacemaker of the entire cardiac system. So that's up here at the upper portion of the right atrium. And so this rhythmically paces, which we'll talk about in much more detail later, but then those signals are conducted through internodal pathways within the atria to reach the atrioventricular node, which is subsequently transmits those signals to the atrioventricular bundle. That goes down these bundle branches to that split here for both the right and left ventricles, and then subsequently spread out into the Purkinje fibers, which allow for the rapid conduction of electrical signals into the ventricular tissue and allow for coordinated contraction. So when we're looking at the speed of cardiac conduction, what you can see here, again, it's very rapid conduction through the atria. Subsequent delays within the atrioventricular node, which allow for a pause between atrial contraction and ventricular contraction, because you don't want those to happen at the same time. You want to have atrial contraction, which provides an atrial kick and just the very last amount of filling into the left or right ventricles, and then subsequently have a very robust coordinated ventricular contraction with relatively rapid conduction of those signals throughout the rest of the ventricle. So from an overall structure as well as timing and rate of conduction perspective, it's actually incredibly useful. Now, similarly, within the cardiac muscle itself, there are gap junctions and what we would refer to as a cardiac syncytium, which enable for the robust coordinated contraction of the left and right ventricles. So just getting the electrical signal there isn't enough. You have to have coordinated, synchronized contraction of cardiac tissue as well, and cardiomyocytes. And so these gap junctions are the structures that enable that. So now that we know the anatomy of the heart, in our next lecture, what we will move towards is how these electrical signals are initiated, propagated, and translated into mechanical actions within the heart. Thank you.